Hello, this is the podcast on the child with malignancy and altered genitourinary status. The concepts we will be covering today include grief and loss, cellular regulation, and inflammation. Usually the causes of malignancy in children include genetic alterations, inheritance, chromosomal abnormalities, immune deficiency, viruses, radiation, and DES. DES, that stands for diethylstilbestrol. And what that is it's an estrogen medication that was given between 1940 and 1971, and it was to reduce the risk of miscarriage in pregnancies. The outcome of this medication was that it gave significantly higher risk and incidences of vaginal malignancies in daughters of the mothers who took this. So understand that other causes can be medications and effects from in utero during pregnancy. When children have malignancies, it is found that more males than females have malignancies. Leukemia is actually the most common kind of childhood cancer. It is a cancer that can grow very fast, and usually by the time the child has the symptoms, it has already metastasized. We are not using leukemia as one of our exemplars due to the fact that in N240, that is one of the cancers that course goes over. So for a reminder, leukemia is a cancer that affects the blood or the bone marrow. Okay. It is actually about 1 in 285 children in the United States will be diagnosed with cancer before the age of 20. So it is not, childhood cancer is not that uncommon, okay? According to the American Cancer Society, 80% of children with cancer survive 5 or more years. So that's a really significant increase. In the 70s, it was about 58%. So really, we've come a long way. We still have a long way to go, but we have improved. After accidents, cancer is actually the second leading cause of death in children ages 1 to 14 years old. So pain, as far as an assessment finding of cancer, is not usually caused by cancer, but it's usually caused by the mass that's pushing on something. For example, obstructing organs, or it's obstructing vessels or bowel. Fever is the body's way of eliciting the immune response. Okay. Petechiae and ecchymosis, this is bruising that occurs. It often and especially occurs over the spleen area. Oftentimes with cancer, there will be an abdominal mass. There can be swollen lymph nodes. A white reflection on the pupil. So this is during eye exams. So they are looking for more than just visual issues on those eye exams. They're also looking for retinoblastoma, and that they can see that when they shine a light in the eye and there is a shine off the optic nerve. That's indicative of retinoblastoma. Frequent headaches with vomiting, so that general feeling of malaise that makes it hard to determine what's wrong with the child. and excessive and rapid weight loss are all assessment findings for childhood cancer. So when a child is taken in for an exam that is more than a normal well child exam, they're going to get a complete history, a physical examination. They're going to get lab studies. And the lab studies that we are specifically talking about are white blood cell count series. So initially, the white blood cell count will be elevated with a child with cancer. Once they have chemotherapy, then you'll see that reduction. Also, we want to look at the red blood cells. So if there are a decrease in red blood cells, we want to see if maybe the bone marrow is being affected. So we're definitely going to do that CBC. Biopsies, we're going to talk about, and bone marrow aspirations. So they're also going to do CAT scans and MRIs. They're going to do a biopsy if they can find a mass, okay? Otherwise, they're not going to. Obviously, this is a child, so just imagine what the parents might be going through and what the effects on the child and the family just with the idea that they could have cancer and they're being evaluated for that. When we're talking about a bone marrow biopsy, there are similar things as with an adult. So the child cannot be on anticoagulation therapy. You have to look for things after the biopsy like bleeding, inflammation, hematoma, and infection, just like with an adult. If it's a young child, they're going to do this bone marrow biopsy or aspiration in the proximal tibia. Older children, they're going to use vertebral bodies like T10 through L4. Some of the nursing diagnoses that are associated with this are fear, inadequate coping, and knowledge deficit. So after the type of cancer has been identified by an MRI or a biopsy, then treatment can begin. And the treatments are, you can read right there, okay? And there's some good videos there with it. The biologic response modifiers, that's very specific. So that is, for example, sargrammogen. It's a recovery agent for the bone marrow. Our most popular type of treatment is chemotherapy and radiation. So when we're doing chemotherapy, we need to remember that there is that blood-brain barrier. So for adults, it's extremely hard for the chemotherapy to get to the brain. More often than not, they never do that. They only do surgery and radiation. But the good news is that children, and the younger they are, the less developed, but children don't have as developed blood-brain barriers as adults. So they do better, they get better results if they have that type of cancer with chemotherapy and radiation, okay? Remember that blood-brain barrier is that semi-permeable border that separates the circulating blood from the brain and the extracellular fluid in the central nervous system, all right? This is what protects the brain from pathogens, all right? All right, so this is a picture of what a child might see when they're going for a diagnostic procedure. This is a CAT scan machine. And right here is a happy place, and right here is a happy place, but right here is sad and scary. So we need to do our best to make this a pleasant experience, as pleasant as possible for the child and the family. Remember that we are almost ambassadors to healthcare. What a child experiences with the healthcare system is how they are going to treat and carry on with their own families their ideas of the healthcare system. We need to constantly be vigilant to that and perpetuate a positive outlook in our healthcare system. All right. All right. So, side effects. A big problem with pediatric cancer is not what the cancer does, but what all of the treatment does. All right. We need to make sure we're remembering our labs. So, our normal white blood cell count, about 5,000 to 10,000. Our normal platelets, 150 to 450,000. We need to know that, all right? Those are numbers you need to know so that you know if something's going wrong. When a child has chemotherapy, one of the biggest things that happens is the child becomes neutropenic, and they develop this huge risk for infection. It compromises their immune system, so you don't put a child in any area where they have a risk for infection. If they are neutropenic, they will be on reverse isolation. If they are neutropenic, we're talking about no fresh fruits or vegetables because of bacteria, no flowers, no crowds, no live vaccines, bottled water, all right? No live vaccines, but make sure you are watching your labs, because not only are we worried about their white blood cell count and neutropenia, but we are also worried about the risk of infection and the risk of bleeding. All right, so we talked about infection with neutropenia. Bleeding is when our red blood cells are affected. The child has a possibility of becoming anemic. All right. If the child is anemic, there is a greater risk for oxygenation issues, right? Because those hemoglobins carry the oxygen, so all that plays in effect. All right. So we need to be very conscious of all of those. Remember, when we're talking about a child who has a risk for bleeding, we want to be vigilant of the fact that we usually, and this is what's different with adults and children, we usually do not ask them to reduce their amount of activity. We might for an adult, but for a child, we don't ask someone with a higher risk of bleeding to reduce their activity, because we still want to keep them on that normal growth and development path, okay? So that's something you're definitely going to see different with adults and children. So we're going to talk about the side effects of treatment. But I want you to understand that if you know anyone with cancer, this has been a very, and is going to be a very basic lecture. This does not paint an entire picture, which I don't really feel like I can do for you. But not only do these children have cancer, but then they have all these horrible, horrible side effects, okay? I don't want to downplay any of this. I simply cannot explain to you the emotional and aspect of childhood cancer to a child and to families. So, although chemotherapies have improved over the years, so have the pre-treatments. So we can treat with Zofran, we can give steroids, and these types of things, and these will help the child get through the chemotherapy with some amount of comfort. There is some chance for hemorrhage issues, so we need to make sure the child gets plenty of fluids and that they are well hydrated. Understand that if they have, because we're hydrating them so well, if they have frequent voiding, we may have issues with bowel and potty training, okay? But the alopecia is another side effect of chemotherapy. It is hair loss. So there's really two different kinds of chemotherapies. The one surrounds the cells and cuts off the food supply, so there's cell death. That kind of chemotherapy, the child does not lose hair. The second kind is where the chemotherapy breaks into the cells and affects its ability to reproduce. And this is where you're going to see hair loss, because hair and skin cells rapidly reproduce, and the chemotherapy doesn't differentiate between healthy and unhealthy cells. So you have a child who has beautiful brown, shiny curly hair, and all of a sudden their hair starts to fall out. That can be very upsetting to parents, if you can imagine. And then unfortunately, when the hair grows back, if it all does grow back, it doesn't always, it may grow back a different color and it may be straight. So this can be a very upsetting thing for families to go through. Steroid effects is another thing that's very difficult. There will be swelling around the face. This is called a moon face, okay, with the swelling. And this is from the steroid use. Usually the effects go away within a week or a little bit more than that, okay, after the treatment stops. So they will gain their features back. But now imagine that the child has lost their hair and their features are now obscured by all this swelling. This can be extremely devastating to families. Pain management is extremely important, and we need to be very cognizant of bowel elimination issues. Constipation is a side effect of chemotherapy. So the reasons that chemotherapy may cause constipation is because there will be usually a decrease in fluid intake, a loss of appetite, lack of fiber intake, low level of activity, and then maybe the cancer is actually obstructing the bowel. So all those are reasons why you might have bowel elimination issues. Okay. Other side effects of treatment, we briefly talked on altered nutrition. We need to watch the eyes and nose. We need to watch the height and weight, give supplements, monitoring the labs. We need to, again, keep them on as good and a positive growth and development track as possible. Mucous membranes are at risk for severe compromise due to the chemotherapy. So there's big risks for alterations. Good mouth care and things like simethicone washes and things to help the pH get lower. They also might need more caloric intake, so we might need to give them calorie dense formulas and things like that. Okay. Graft versus host disease. So many people confuse this with transplantation rejection. This is not transplantation rejection, okay? This is when the body is basically attacking itself. It can be very fatal. It occurs when the transplanted tissues, so for example, stem cells, non-irradiated blood products, bone marrows, or even organs, are transplanted and still have the donor's white blood cells remaining. Those white blood cells then start to attack the recipient cells. So, in other words, we do this transplant and there's still white blood cells in there, and then they start attacking that recipient. Well, if you do a bone marrow transplant, you can't take that out again, so you're going to have to be giving meds that help. So high dose steroids, immunosuppressant drugs, those types of things, okay? So, as far as education begins immediately. We need to educate specifically and honestly. The first thing you have to do is talk to them like a healthcare professional. So talk to them not like a child and not use large medical terms that would make some people feel like you're being condescending, okay? So we need to explain to the parents at their level. We can later then explain to the child at their own level. We must be very honest about what is to come, what they are going to see. And as you can see here, we have to talk about the pathophysiology, the diagnostic procedures involved, treatment options, pain management, management of all the side effects. So we might have to talk about the side effects of all the chemotherapy, the radiation, where they have what might look like burnt skin or sunburn or blisters. Managing those side effects, nutritional interventions that might be needed, care of central venous catheter accesses, so central lines, ports, PICC lines, what they're going to need to do at home, coping, and long-term effects, which we're going to talk about in just a minute. So there are all kinds of psychosocial interventions that we need to do because we are treating way more than just the patient, right? We're treating a whole family. As we are treating the family, we're not just treating the body, but we're also treating the mind, right? So children who have cancer, especially teenagers, can suffer from really disturbed body image. So what they really need to work on is that we need to really explain to them, that they may lose hair, that they may have a moon face from the steroids. There may be rashes, scarring, mouth issues. There may be a port that you can see that's under the skin, right? Along with all that, there are other stressors. So there are financial stress. So if both parents work, they may have to keep working to pay for the treatments. So they have a child who's in the hospital. It might be very difficult for them to stay a lot with this child because they may have to work to pay for all the expensive treatments. Understand that a family's initial response is going to be denial. They need time to process. They need education and reassurance. All right. So, that's our job as nurses. It's not just about physical interventions, but it's also about the care we give. All right. And psychological interventions as well. When we have a child with a malignancy or any kind of childhood illness, we need to make sure that we are monitoring this child for appropriate growth, right? We have to make sure they're still growing physically, emotionally, and intellectually. Sometimes, depending on how sick they are, it's very hard to do anything about their physical growth, but we can do something about their emotional and intellectual growth, right? We have to be able to choose activities that will stimulate them. Choosing puzzles and and getting tutoring services set up for them. We have to be able to help the child and the family see beyond the cancer and not let the cancer define who the family is. All right? This cannot encompass the entire family for the length of the time that the child has cancer. They have to be able to live as well, okay? And this will conclude our first portion of the lecture on the child with malignancy and altered genital urinary status. Thank you.